Bonding and banding in orthodontics. Bonding will include bracket placement, adhesives, and bonding techniques. The bracket is positioned in 3D manner: mesiodistal position, axial position, and vertical position. It is a general saying in orthodontics that brackets should be placed at mesiodistal center of the teeth. This statement is partially correct, as this rule cannot be applied to all the teeth. A more clear description for right mesiodistal position of the brackets is that the bracket should ideally be placed at the mid-developmental ridge of the teeth. Maxillary and mandibular incisors. Bracket should ideally be placed at the mesiodistal center of the maxillary and the mandibular incisors. The mid-developmental ridge is present at the mesiodistal center of the labial surface. Maxillary and mandibular canines. Placing brackets at the mesiodistal center of the canines will result in contact point error and slight rotation of the teeth. At the mid-developmental ridge of the upper and lower canine lies slightly mesial to the mesiodistal center of the teeth and is more mesial in case of lower canines. So brackets is placed slightly off-center and toward mesial in case of canines. Mandibular premolars. Sometimes the area of maximum convexity lies in the mesiodistal center or slightly mesial to it, but in less degree than that of the canines. Presence of a lingual cusp on premolars must be taken into consideration while placing the brackets. The buccal and lingual cusps lies at the same level in the mesiodistal perspective. Maxillary premolars. According to Andrew, the buccal cusps of the upper premolar should be slightly more distal than the lingual cusps in the mesiodistal perspective. Bracket should be placed so that the scribed line of the bracket is slightly mesial up to 0.5 mm to the line connecting the buccal and lingual cusps. Bonding the brackets in this position will rotate the buccal cusps distally and lingual cusps slightly mesial to get ideal relationship in class 1 molar relation. Maxillary and mandibular molars. Whether molar bands or tubes are used, the optimum mesiodistal position is decided by taking the mesiobuccal cusp as a reference. The mesial opening of the tube should lie below the mesiobuccal cusp at the correct vertical height. Checking mesiodistal position of the brackets. The mesiodistal position of the bracket can be checked under both direct and indirect vision. For indirect vision, diagnostic mirror is used. Generally, mesiodistal position of upper incisors, premolars, and molar brackets is checked under indirect visions. Modifications in mesiodistal position of the brackets. Number 1. Rotated teeth. Bracket should be placed as far as possible toward the mesiodistal center of the tooth or toward the rotation. At subsequent visits, the tooth is usually derotated enough to place bracket at the right mesiodistal position. Number 2. Maxillary lateral incisors substitution by canine. The slightly convex labial surface of the canine is made flat to give its shape of the lateral incisors, and the bracket is bonded at mesiodistal center of the reshaped canine instead of slightly mesial. On premolar, the canine bracket is placed distal to the mesiodistal center of the tooth to rotate the tooth mesiopalatally, which increase the mesiodistal width of future canine tooth and help to hide the palatal cusps of premolar. Axial position of the brackets. Axial or long axis position of the bracket is related to the angulation or tip of the teeth. In pre-adjusted edgewise system, brackets are positioned on the tooth so that their wings and scribed lines are parallel to long axis of the clinical crowns or the long axis of the tooth. Checking axial position of the brackets. The axial position of the brackets is checked under both direct and indirect vision. Usually maxillary anterior brackets and mandibular brackets are checked under direct vision from labial side of the tooth, while maxillary posterior brackets are checked under indirect vision using diagnostic mouse mirrors. If there is doubt in position of the maxillary anterior brackets, especially lateral incisors bracket, some clinicians favor to use indirect vision by diagnostic mirror and use guidance from lingual side of the tooth. Modifications in axial position of the brackets. Number 1. To accommodate crown morphology for achieving golden proportions of connectors and embrasures. Number 2. To avoid root resorption from dental or orthodontic implants. Number 3. To avoid root resorption from teeth impacted in bones such as impacted canines or mesiodens. Vertical position of brackets. From the time of bracket evolution till date, orthodontists have much debated the vertical position of the bracket but have failed to reach a consensus to lay down a uniform protocol. With the advent of straight wire appliance, vertical position of the brackets gained more importance, as morphology of the tooth is not uniform throughout its length. Changing the vertical position of the brackets will result in different expression of its built-in prescription. Almost every orthodontist who devised a bracket prescription also has advocated a certain vertical position for those brackets so that the built-in prescription should be fully expressed. Andrew guidelines for bracket placement. Andrew proposed that when the teeth are ideally positioned, the middle of each bracket side must be at the Andrew plane, where Andrew plane is a surface plane on which mid-transverse plane of every crown in an arch will fall when the teeth are optimally positioned. Ross guidelines for bracket placement. Ross, like Andrew, also proposed center of a conical crown for ideal bracket placement to be used with his prescription. However, Ross advocated that for his prescription, anterior bracket should be placed slightly more incisal than Andrew proposed to level the curve of P. MBT guidelines for bracket placement. McLaughlin, after conducting 4 different studies on crown height, proposed his own method of bracket positioning. The method consists of measuring crown heights, matching obtained values with McLaughlin proposed charts formulated from his study, and placing brackets by special gauges. Selection of optimum vertical height. As so many guidelines are present for vertical height, the clinicians are often confused which height should be chosen. Till the orthodontists don't agree on a single reliable and reproducible method of vertical bracket positioning, the best solution is to use a vertical height that is advocated by the inventor of the prescription. Experience and knowledge with time will lead many clinicians to use a modified vertical position of their own, which work with certain prescription on a certain population group. Checking vertical position of brackets. Bracket positioning gauges. Bracket positioning gauges are used to ensure vertical accuracy of brackets on the teeth. In contemporary orthodontics, 2 types of gauges or their variation are usually used. There are star-shaped gauges or bone bracket gauges, straight rod-shaped gauges, or dove-tree gauges. All bracket positioning gauges have a holding arm for holding the gauge with finger during bracket positioning, a tooth supporting arm which rests on the incisor or occlusal surface of the tooth, and a slot supporting arm which is seated in slot of the bracket. Different slot supporting arms are available for 18 and 22 slots. Modification in vertical position of brackets. Number 1. Open bite. In open bite cases, if the plane is to non-surgically treat the case, then it is advised by many clinicians that bracket position should be modified to close the bite. This is done by plating the brackets more gingival on the tooth which are in open bite. Deep bite. In deep bite cases, brackets are bonded following opposite rules of the open bite cases. Irregular incisal edges. If it is planned to recontour at the end of the orthodontic treatment or composite filling is needed at the end of the treatment, then height modification of the bracket is done at the start of treatment. Usually composite filling is reserved for cases with open bite or large broken areas of incisors. Attrition of the canine. In case of attrition of the canine, the brackets are placed 0.5 to 1 mm more gingival depending upon the severity of attrition. The canine tip is reshaped at the end of treatment. Gingival recession. Individual teeth with up to 1.5 gingival recession can be bonded more gingival so that at the end of the treatment the gingival margin should be at the ideal height, but incisors or occlusal edge needed to be reshaped by equal amounts. Bonding adhesive. Composite resins, which includes chemically cure, light cure, dual cure, conventional moisture insensitive or self-etch. Also it includes glass ionomer cements. Bonding techniques. Bonding. The steps of bonding are tooth cleaning, isolation and moisture control, enamel roughening of the labial or lingual surface of the tooth by acid etching, sealing of the etched surface, then bonding. Tooth cleaning. This step is done at time of bonding. If only plaque or thin pellicle layer is present, pumiceing of the tooth alone is sufficient. If calculus is present, scaling is done, which is followed by pumiceing. Used polishing base should be both oil and fluoride free. Isolation and moisture control. Good moisture control is provided by using check or lip retractors, high volume suction and cotton roll. Enamel roughening or acid etching. Enamel conditioning can be done by 35 to 37 phosphoric acid sandblasting, combination of sandblasting first followed by conventional etching, which can be also done by laser, may be used alone or in combination with acid etching. It is always better to etch the enamel surface only on the future bracket setting area. When large area of the enamel is etched and the clinician don't seal it by primer, these rough surfaces act as future plaque retention areas. Etching should be done for 25 to 60 seconds. The enamel surface is then dried with oil-free air. Enamel should be frosty white after drying the etched surface. The dry etched enamel surface is sealed with a thin coat of primer or bonding agent with the help of a primer brush. Direct bonding. A thin layer of adhesive is applied over the bracket and the brackets are placed over their proposed final position of the teeth. A heavy force is applied from the back of the bracket holder to squeeze out any extra composite from underneath the bracket. Flash composite is removed by dental probe. Once all the position of the brackets are checked, the bracket is cured in its place for 20 seconds with LED curing light. Indirect bonding lab method. In indirect bonding, brackets are first individually placed on patient's dental cast and then transferred by special carrier trays in the patient's mouth. Indirect bonding is a routine step in using lingual orthodontics. Also, it can be used with conventional bonding to accurately place brackets and save bonding time in clinical practice. An impression of the patient teeth with dimensional staple impression material is taken and poured in dental hard stone. Water-soluble separating medium is applied over the dental model. Brackets are placed over the dental model in the same way as done in direct bonding by using water-soluble adhesive or conventional bracket adhesive. The bracket should be placed at the ideal location on the model. A very thin layer of water-soluble separating media is then applied on the bonded brackets. After applying the separating medium on the brackets, 1 mm thin soft silicone tray is vacuum formed over the brackets. Then a 1 mm thick hard silicone tray is vacuum formed over the soft tray. This outer layer tray will support the inner soft tray and prevent it from distorting during insertion in the mouth. The trays are cut with a disc on the lingual side so that it covers half of all the clinical crowns. On the labial side, the tray is cut at level of the gingival wings or hooks of the brackets if present. The model is then immersed in water for at least 10 minutes to dissolve the separating media. After 10 minutes, the trays along with brackets are removed from model in one piece and remain adhesive is removed. The patient teeth are cleaned and etched similar to direct bonding. Good isolation of teeth and high volume suction is necessary as whole arch is etched in a single go. Adhesive is applied to the base of the brackets when the trays are fitted intraorally. Once the trays are firmly seated, movement of the trays should be avoided. Finger pressure should be maintained over the trays during curing. After curing, the tray is peeled and the position of each tooth is checked clinically. Flash adhesives are removed by hand or ultrasonic scaler. If a bracket is not placed on its ideal location, it would be debonded directly. Indirect bonding digital methods. The steps are scanning, designing, then delivering. Bonding in special circumstances. Number 1. Etching for bleached enamel. The previously bleached enamel have been reported to decrease bonding strength, so different waiting times have been recommended before bonding. The range of waiting time is 24 hours to 14 days. Etching of abnormal enamel. Resin-modified glass ionomer cement is usually chosen for cases with amelogenesis and dentinogenesis imperfecta, as it is generally thought that it provides lower bonding strength than composite resin. Bonding brackets to composite restorations. Composite resin have a good adhesion with orthodontic adhesives. Micro-retention on these restoration is done by roughening their surface with diamond bare with or without etching with phosphoric acid. After roughening, most clinicians bond the brackets without application of a primer on the restoration surface. Bonding on porcelain or ceramics. Porcelain crowns and veneers must be roughened before bonding. There are several methods for roughening the porcelain surface, such as diamond bares, sandblasting, conventional etching and silane coupling agent, a 6 to 9.6% hydrofluoric acid with silane coupling agent, and iridium ragi laser. Banding. Banding includes the bands, the banding techniques, and cements. Indication of banding. Teeth that will receive heavy intermittent force against the attachment, such as the upper first molar. Teeth needing postlabial and lingual attachments. Teeth with shorter clinical crowns. To surfaces that are incompatible with successful bonding, amalgam restoration, porcelain veneers, and enamel fluorosis. Requirements of orthodontic band. An orthodontic band must fit the contour of the tooth as closely as possible. Width of band material and cement in the interproximal spaces should be kept to minimum. There should be no cement on the occlusal margin with subsequent collection of food debris and decalcification of tooth. There should be no gingival overhangs to prevent periodontal problems. Good separation is necessary. It assists accurate banding placement and makes the procedure more comfortable for the patient. Ideally, elastic separating module should be in place for about a week. Less than a week can cause sensitivity of the teeth during band placement. There is a great risk of separators failing out if they are left in for more than a week. Steps for band selection. Upper molar band placement. The upper molar tubes should straddle the buccal groove, and this can be checked by viewing from the occlusal surface. Care is needed to prevent the distal aspect of the band from sealing too gingivally, and band seating pressure is therefore applied at the mesial palatal aspect initially, then the distal palatal aspect. The band should be checked from the buccal to ensure it is parallel with the buccal cusps. Lower molar placement. The lower first molar tube should straddle the mesiodistal buccal groove. This should be checked by viewing from the occlusal. Care is needed when bending larger lower first molar to ensure that the tube is not placed far too mesially, and also to prevent the mesial aspect of the lower molar bands from seating too gingivally. Lower molars should be checked from the buccal to ensure that they are parallel with the buccal cusps. Convertible tubes are more bulky than non-convertible tubes, leading to occlusal interferences and the tendency to place the bands too gingivally. It is therefore easier to place lower bands with non-convertible tubes. Orthodontic cements. Water-based cements. Zinc oxyphosphate cement. Zinc phosphate acts only as a luting cement as it does not bond directly to either tooth or band surface. Luting agents only act as a passive filler. Zinc phosphate cement also is slowly soluble over time. This slow loss of cement can promote decalcification of the tooth near the margin of the band. Zinc polycarboxylate cements. These were introduced as an alternative to zinc phosphate cement with the advantage of chemically adherence to the enamel. Unfortunately, the polycarboxylate cements have a poor tensile strength, increased solubility, and short working time. They are no longer used for orthodontic applications. Glass ionomer cements. Glass ionomer adhere to enamel and metal and have a good compressive strength. They are also protect the teeth from micro leakage, since any bond failure usually occurs at cement band interface, leaving the cement tooth enamel interface sealed and protected by the intact cement. Furthermore, they slowly leach fluoride over a prolonged period, which is thought to reduce the potential for demineralization. Despite their obvious improvements, they have technique sensitive steps with mixing that can affect the final physical properties of the hardened cement. Manufacturers have developed capsules for mixing which have improved the consistency of mixing process. Resin modified glass ionomer cements. Glass ionomer cements were modified by incorporating resins for more strengths, water-soluble initiators and activators to produce a dual-cure hybrid cement that was easier to mix with a longer working time and a more controlled setting time. It is thought that the addition of the resin reduced fluoride leaching, thus reducing the anti-caries effect of the traditional glass ionomer cement. Resin-based cements. Acid-modified composite resin cements. These compomer or composite cements are composed of ion-leaching glass in a polymeric matrix. They are cured through a light-activated reaction but not by chemical reaction commonly used by previous cements. The handling characteristics are generally good, including minimal mixing and increasing working time. As with other cements, compomer has some negative properties as these cements, unlike the glass ionomer cement, usually fail at enamel cement interface instead of cement band interface, thus leading to higher risks of decalcification and white spot lesions under a band that does not appear or act loose. Different types of cements used in orthodontics.